new session, and this is the last chapter of autonomic nervous system. Today we are going to speak about adrenergic antagonist. As you can see here from the background with the front slide, we already presented there. We are going to discuss adrenergic antagonist. We have another name for adrenergic antagonist called like adrenergic blockers. So we are going to speak about two main group, alpha blockers and beta blocker. And this section here for blockers, for alpha and beta blocker, considered one of the most important section in the clinical pharmacology, one of the most important section in the clinical practice, because we use it for treatment of so many diseases. For example, angina, hypertension, myocardial infarction, benign prostatic hypertrophy. We have the Raynaud's disease. We have a lot of cases we use this medication to treat. Okay, stay tuned and we'll start soon. Again, as you can see from the slide here, we have group of medication. The first group of medication here in the top, for example, here we have a group belong to the beta blocker, propranolol, prototype, followed by metoprolol. Propranolol, it's considered like beta 1 and beta 2 blocker, metoprolol, beta 1 blocker, labetalol, block beta 1, block beta 2 and block alpha, carvedilol, block beta 1, block beta 2 and block alpha, timolol. This medication belongs to the beta blocker, but mainly used for the eye as eye drops. Nevibilol, one of the new generation of beta blocker. So the top will belong to the beta blocker. Now here in the bottom here we have phenoxybenzamine, considered like phenoxybenzamine non-selective alpha blocker. Then we have Prazosin alpha 1 blocker. Then we have doxazosin alpha 1 blocker. Tamsulosin, we have alpha 1A blocker. So we are going to speak about all these drugs and agent, and we'll talk about the clinical application, side effect, or if there is any side effect, we can cover it there. Okay, so you can see here we have we add another medication, and we have another medication called phentolamine. So phenoxybenzamine block alpha, phentolamine block alpha, but we have some differences between these two medications, phenoxybenzamine and phentolamine. So we are going to cover that later on. Okay, so what we are going to see there regarding the adrenergic antagonist, another name for adrenergic antagonist will be beta blocker. Okay, so another name for adrenergic agonists will be adrenergic blockers. So we are going to speak about alpha blocker, beta blocker. We have some agent like alpha and beta together. Then we have some agent affect release and transport of these mediator from the neurons. Speaking about the alpha blockers, we have. Speaking about alpha adrenergic agonist, another name alpha blocker, we have Prazosin, we have terazosin, doxazosin, Cardora, we have tamsulosin, Flomax, we have alvazosin, phentolamine, phenoxybenzamine, phentolamine, the brand name Regitine. Okay, so regarding the alpha adrenergic blocker. Okay, what happened with the beta adrenergic blocker? List of name and the suffix, we need to remember that. We have lol, the prototype. First medication on the list will be propranolol indiral, atenolol, brand name Tenormin, metoprolol, we have two brand name Lebrosor and Tibrol XL. Then we have nadolol, Corcard, nadolol, timolol. Then we have bisoprolol, esmolol, nebivolol. So all these considered like beta blocker. We have another category we are going to speak about later on. So we have another classification for beta blocker. Moving to the another group, alpha and beta blocker alpha. So we have medication block alpha and beta together. Two medication, we have carvedilol and labetalol, as you can see here. Carvedilol, Coric, and then we have labetalol trandate. What about medication affect the neurotransmitter uptake and release? We have reserpine and we have yohimbine. So two medication will affect the transmitter, neurotransmitter uptake and release, reserpine and yohimbine. Okay, so we have the category in the first slide. If you go back to show you what we have in the first slide, we have category there, a general category, and now next slide we are going to speak about subcategory. So for the category here, we're talking about alpha adrenergic antagonist or alpha blocker. Then we have three group of belong to the alpha. We're talking here about medication that block receptor. We call this one blockers. So we have non-selective alpha blocker. We have phentolamine and phenoxybenzamine. So give me medication belong to the alpha blocker and block alpha non-selectively, like block alpha 1 and block alpha 2. We have phentolamine and phenoxybenzamine. Moving to the next one. Moving to the next category, subcategory, we have alpha 1 selective. Regarding alpha 1 selective, we have less of medication. We have doxazosin, Prazosin, terazosin, alvazosin, tamsulosin, and Silodosin. All these considered like alpha 1 selective. Moving to the alpha 2 selective, we have yohimbine. It's not popular in the clinical practice. Again, for alpha blocker, we have non-selective, we have phentolamine and phenoxybenzamine. No. We have phentolamine and phenoxybenzamine. Okay, phentolamine, phenoxybenzamine, non-selective. For alpha 1 selective blocker, doxazosin, Prazosin, terazosin, alvazosin, tamsulosin, and Silodosin. Alpha 2 selective blocker, we have yohimbine. What about beta-adrenergic blocker, beta-adrenergic antagonist? Okay, beta-adrenergic antagonist, we need to remember that we have first generation. We have first generation, as you can see here. For first generation, considered like non-selective group of medication, beta blocker, and the suffix will be lol. The first medication in this list will be Propranolol, followed by Timolol, Sotalol, Nadolol, and Bindolol. So we are going to discuss this medication in detail later on. The second generation, it considered like beta 1 selective. We have acebutolol, atenolol, bisoprolol, esmolol, metoprolol. Okay, this is the second generation, beta 1 selective. And the most important one here will be atenolol, will be metoprolol, atenolol, and atenolol, metoprolol, esmolol, bisoprolol, all these medication important. Moving to the third generation. In the third generation, we have a group considered like non-selective third generation. We have carvedilol, labetalol, bucinodolol, and cartulol, non-selective, cardulol and carvedilol. Carvedilol, labetalol, non-selective beta blocker. What about third generation beta 1 selective? Third generation beta 1 selective, we have nebivolol, betaxolol, and celiprolol. So nebivolol, betaxolol is like the most important one, nebivolol in the practice. So we need to remember this group of medication. And someone may ask, give me medication belong to the third generation non-selective, propranolol. Give me medication belong to the second generation beta 1 selective, we have atenolol. Give me medication belong to the third generation non-selective, we have labetalol. Give me medication belong to the third generation beta 1 selective, we have nebivolol. So this gives us a category for the subcategory for the alpha blocker and beta blocker. Okay. Again, this is what we have. We are going to discuss it in more detail for alpha and alpha blocker, alpha adrenergic antagonist. Okay, the first one here, as you can see, we are going to discuss these two medication here. We have phentolamine and phenoxybenzamine. Okay, regarding phentolamine and phenoxybenzamine, as you can see here, phenoxybenzamine considered like this group medication. Before we talk further on this medication, this is considered like alpha adrenergic blocker, non-selective, that means block alpha 1 and block alpha 2. This is important things for us. A limited clinical application because it's not selective, and a reversible non-competitive blocker, phenoxybenzamine irreversible, bind to the receptor and remain on the receptor. Many clinical use pheochromocytoma. Pheochromocytoma is a tumor in the adrenal medulla. So the patients suffer from increased level of epinephrine and norepinephrine. The patients suffer from hypertension crisis. So we can use phenoxybenzamine as palliative therapy to control hypertension and antagonize the action of epinephrine or epinephrine. Again, we need to remember important issue here. This medication, phenoxybenzamine, irreversibly non-competitive block the alpha receptor. What about phentolamine? Phentolamine is again limited clinical application, non-selective, that's fine, the same, non-selective, both of them non-selective. We have non-selective, but phentolamine considered like competitive reversible alpha 1 and alpha 2 receptor. Okay, phenoxybenzamine and phentolamine could be used for patients from Raynaud's disease. So now could be used or could be treatment for patients with the Raynaud's disease. Okay, in this case here we are talking about two medication with a similar mechanism of action, but we have several modes. Phentolamine reversible competitive blocker, phenoxybenzamine irreversible non-competitive blocker. What happens there if when you block alpha? Here we have the consequences as you can see here. When you block alpha receptor, you block alpha 1 receptor, the result will be decreased peripheral resistance. This will lead to the decreased blood pressure, and this will lead to the something called reflex tachycardia. So this one, reflex tachycardia, this process here related to the reflex arcs. We are going to speak about later on about reflex arc, about reflex tachycardia, because the blood pressure decrease, the heart try to compensate by decreased heart rate. Again, when you block alpha, the result will be decreased peripheral resistance, decreased blood pressure. Okay, if someone may be interested to know how this affect the blood pressure, we know we have equation, and the equation blood pressure is equal to cardiac output multiplied by peripheral vascular resistance. Peripheral resistance here, as you can see it, okay, our medication decrease peripheral resistance, that will decrease blood pressure. So this is an easy explanation for alpha blocker. Okay, this graph here represents the concept of competitive reversible antagonist among Prazosin and the epinephrine. As you can see here, when we prescribe Prazosin to your patient, the Prazosin will bind to the alpha receptor. This is number 1, bind to the alpha receptor. Number 2, block alpha receptor. And number 3 will prevent binding epinephrine to the receptor. So the result of binding of Prazosin will be blocking the receptor and prevent epinephrine from binding the receptor. And we have consequences like vasodilation, decreased vascular resistance, decreased blood pressure. So what happened here if we discuss the low mass of action? If the epinephrine concentration increase at the receptor site, so when we have a higher concentration of epinephrine will come back again to the receptor, displace the Prazosin and activate the receptor. So the relationship now between Prazosin and epinephrine like competitive relationship. When you prescribe Prazosin to the patient, Prazosin will bind to the receptor and prevent epinephrine binding to the receptor. However, when the epinephrine, if you increase epinephrine concentration, this will lead to the displace of Prazosin from the receptor and occupy the receptor. We call this one low mass of action. Okay, so again, related to the binding to the receptor, we have two types. Number 1, we have reversible competitive, and our example was Prazosin block the receptor and displace epinephrine from binding or block epinephrine. We try to overcome this binding by increasing level of norepinephrine. When you increase level of norepinephrine, the result will be displace, remove the prazosin from the receptor and activate the receptor. And here we talk about alpha-adrenergic receptor. Prazosin considered like alpha blocker. So prazosin alpha blocker bind to the receptor, block the receptor. When we try to recover from this blocking receptor, we can increase level of norepinephrine, and this will displace prazosin from the receptor and activate the receptor again. Regarding non-competitive irreversible antagonists, we have example phenoxybenzamine, and phenoxybenzamine block alpha-1 and alpha-2 receptor, adrenergic receptor. So phenoxybenzamine bind to the receptor and block the receptor, preventing epinephrine from binding to the receptor. Not only epinephrine and norepinephrine also. So phenoxybenzamine bind to the receptor irreversibly. That means the phenoxybenzamine will bind and remain and stay on the receptor. What happened if you increase level of epinephrine? If you have high concentration of epinephrine. So what we have here, as you can see, the phenoxybenzamine stay on the receptor even if we have high concentration of epinephrine. This concept, we call this concept non-competitive irreversible antagonist. Okay, so speaking about some selective competitive alpha-1 blockers, normally we prefer to go the selective, because when you start to speak about selective medication, that means we have maximized the effect and minimized the side effect for the medication. So what we have here regarding this list of group, we have Prazosin, terazosin, doxazosin. This is alpha-1 blocker. We have tamsulosin, Silodosin. Tamsulosin and Silodosin considered like alpha-1A blocker. So we have this the first three considered like alpha-1 blocker: Prazosin, terazosin, doxazosin, and this three medication indicated for the treatment of hypertension. This medication block alpha-1 receptor, lead to relaxing blood vessels and decreasing blood pressure. If you prescribe this medication to your patient, the patient may suffer from syncope or fainting due to the hypotension. So the initial dose may cause hypotension, or like we call this one orthostatic hypotension, and this will lead to the syncope and fainting. To minimize this syncope and fainting, we try to ask the patient to take 1/3 of the dose. Start with a lower dose, 1/3, and then 1/4, and to the normal dose. So start with the small dose, then escalate the dose. This is number one. Number two, we have administer this medication during bedtime, because with the orthostatic hypotension, this hypotension happened during when the patient is changing position from sleeping to upright or from sitting to standing. The patient starts suffering from hypotension. Therefore, to prevent orthostatic hypertension, take this medication at bedtime before you sleep. The second group of medication belong to the alpha-1 blocker. This medication, we have tamsulosin, Silodosin. We have alpha-1A receptor. So this medication block alpha-1 inhibit or block alpha-1A receptor. As you can see here, this group of medication is more selective. So this one here is only block alpha-1, but here we have block alpha-1A receptor. This will minimize effect on the blood pressure. Okay, because only alpha-1A available on the bladder and the smooth muscle of the prostate. It's mainly available in the smooth muscle of the prostate. So if you block this smooth muscle, this will be ideal for the treatment of benign prostatic hyperplasia, and this will help relieve symptoms, urinary symptoms associated with the benign prostatic hyperplasia, and relaxing the prostate and bladder neck muscles. So this approach now, we can ask question: which of following medication belong to the alpha blocker used for treatment of benign prostatic hyperplasia? We are here we talk about tamsulosin and Silodosin. Okay, speaking about what we have here regarding the receptor, as you can see here, where the bladder innervated by parasympathetic and sympathetic nerve, and you can see here we have in the bladder we have muscarinic receptor. In the bladder we have beta-adrenergic receptor, muscarinic receptor M3, beta-adrenergic receptor we have B3. So when the muscarinic receptor activated, the result will be contraction, And when the beta 3 activated, the result will be relaxation. And also they try to remind us we have alpha-1 adrenergic receptor in the prostate and the bladder neck. We have in the bladder neck we have alpha-1 in general. So all these considered like target for us. So mirabegron considered like beta-3 agonist. Mirabegron, beta-3 agonist, and mirabegron stimulate beta-3 receptor and lead to relaxation of smooth muscles, of detressor of smooth muscle, longitudinal muscles. Here we are talking about longitudinal muscles, relaxing the bladder and allow the patient to hold the urine for a long time. For this reason, we use mirabegron for overactive bladder. Treatment of overactive bladder. Okay, another medication, oxybutynin. Oxybutynin considered like muscarinic antagonist, as you can see here, muscarinic antagonist. How this medication work? You can see here the oxybutynin block the muscarinic receptor, because if you stimulate M3 receptor, muscarinic receptor, the result will be contraction. What happens if you block muscarinic receptor? The result will be relaxation. So the medication now for overactive bladder, we have two medication. You can see number one, we have mirabegron, considered like beta 3 agonist. Then we have oxybutynin, muscarinic antagonist. Okay, for the benign prostatic hyperplasia, we have two medication, tamsulosin and silodosin, block alpha-1A in the prostate and the bladder neck, and this will use for benign prostatic hypertrophy. Okay, so how this medication work? Tamsulosin, Prazosin, block alpha-1A receptor in the prostate and bladder neck. A group of medication used for hypertension but could affect the bladder also. Here Prazosin, terazosin, doxazosin, can we use it for the benign prostatic hypertrophy? The answer yes, but we have here yes, comma, but. What that mean for us? This medication, this group of medication, Prazosin, terazosin, doxazosin, will be ideal for patients suffering from hypertension plus benign prostatic hypertrophy. So this one will be great for the patients from these two cases, hypertension and benign prostatic hypertrophy. What happened with this group of medication here? So you are going to see patient in the clinic suffer from benign prostatic hypertension, benign prostatic hyperplasia, but blood pressure is normal. Okay, the ideal therapy here will be tamsulosin and silodosin. No need to decrease blood pressure. In this case, this group of medication, tamsulosin and silodosin, have minimal effect on the blood pressure and maximum effect on the bladder and prostate. Okay, the next topic, next important topic related to the autonomic nervous system will be beta-adrenergic antagonist, and this is important topic for the clinical application. So let's get started. Okay, as you can see here in this table, beta-adrenergic agonist, we have three generation: first generation, second, and third generation. The first generation considered non-specific generation, as you can see here, non-specific generation, the first generation, and for the first generation, non-selective beta blocker, antagonist, beta-adrenergic antagonist, another name, beta blockers. So for the first generation, non-selective, we have propranolol, timolol, sotalol, nadolol, and benzolol. Moving to the second generation, we have beta 1 selective blocker. We have acebutolol, atenolol, bisoprolol, esmolol, and metoprolol. Okay, third generation, we have two main groups. The first group of third generation non-selective, we have carvedilol, as you can see here. We have labetalol and bocedonolol, and then we have cartulol. Beta 1 selective, to speak about beta 1 selective, we have nebivolol and betaxolol and celiblorol. So three medication. So shall we highlight the important medication here? Let me highlight the important medication on the list. Propranolol, timolol, sotalol, very important medication in the practice, atenolol, metoprolol, esmolol, bisoprolol, very important medication in the practice, carvedilol, labetalol, and we have cartulol, nebivolol, betaxolol. All these medications considered like important, but we need to remember which one is first medication, which one is selective, which one is non-selective, and we have the reason for this category here. Okay, so the prototype for the beta blocker, we have propranolol. We are going to discuss propranolol with you here. We have propranolol. The prototype will be the propranolol. As you can see, we try to maybe understand the effect of propranolol on the. Okay, start maybe understand the effect of propranolol on the heart, on the lung and eye, and in patient with diabetes. Propranolol considered like non-selective beta blocker, non-selective beta agonist. That means propranolol block beta 1 and propranolol block beta 2 also. So blocking beta 1, we know that beta 1 mainly available in the heart. Beta 1 mainly available in the heart, and if you block beta 1, the result will be decreased heart rate. We call this one chronotropic. The result will be decreased contractility. We call this pattern like inotropic, chronotropic. So negative inotropic, negative chronotropic. So the result will be decreased blood pressure, and the result will be peripheral vasoconstriction. So we have several effects of the propranolol in the heart. Let me repeat that. The propranolol effect on the heart, number one, decrease heart rate. This is number one. This is number one, decrease heart rate. Number two, decrease contractility. Number three will be decreasing blood pressure. Number four, some patient may suffer from peripheral vasoconstriction, and we have the explanation for that. And I prefer to go to the whiteboard again, explain what happened there in order to understand the concept. So looking for what happened with the propranolol, as you can see, first of all, we need to understand the following. We have equation, blood pressure equal to the cardiac output multiplied by peripheral vascular resistance. We know that in the cardiovascular effect here, we are talking about the heart. And in the heart, we have mainly we have beta 1 receptor, beta 1 adrenergic receptor, and propranolol. Propranolol block beta 1 receptor. So the result will be decrease cardiac output. Okay, so blood pressure here and multiply peripheral resistance. Okay, this result will lead to the decrease. This will lead to the decrease in the blood pressure. So you can see here, due to the decrease in the, let me clean this one, just 1 minute. Okay, decrease cardiac output. And decreasing cardiac output, this will lead to the decreased cardiac output, this will lead to the decreased blood pressure according to this equation. But they start looking on the peripheral resistance, what happened there, what they found later on, if you can go back to the first slide, we discussed that in the first slide, me and you together. So they look on the blood vessels. When you look on the blood vessels, and we already discussed that, we have okay, in the blood vessels, we have two types of receptor. We have beta adrenergic receptor, beta 2 adrenergic receptor, and we have alpha 1 adrenergic receptor. And beta 2 will be predominate in the blood vessels. Here we have talking about blood vessels, and here especially about skeletal muscle blood vessels. So what we have here, as you can see, our medication propranolol will block beta 2 receptor. So our medication will block beta 2 receptor. So the result here, because we have balance between beta 2 and alpha 1, so when you block beta 2 receptor, this gives the opportunity for alpha 1 to predominate and produce their effect. And we always mimic this situation like like we are having river, and this river has we have river here, we have river, and this river maybe have the two branches. We have beta 2 branch, and then we have alpha 1 receptor branch. So if you block beta 2 receptor, the activity of alpha 1 will increase. So increasing activity of alpha 1 receptor, this will lead to the vasoconstriction. Okay, so peripheral vasoconstriction could be ADR, adverse drug reaction of epinephrine. So this explains why the patient may suffer from peripheral vasoconstriction, as you can see here. So this is done with what we have about heart. Number one, decreased heart rate. We have decreased heart rate, number one. Number two, decreased contractility, and we have terminology for that: chronotropic, inotropic. The net effect will be decreasing blood pressure, and some patient may suffer from peripheral vasoconstriction, and we explain the mechanism. For the respiratory system, we know that beta 2 available in the bronchial tree, and if you activate beta 2 receptor, the result will be bronchodilation. The result will be bronchodilation. For this reason here, what happened here? Propranolol, I will change the color here a little bit. Propranolol, this medication here, propranolol, will block beta 2 receptor, and the result will be bronchoconstriction. So do you recommend prescribing this medication for the patients from asthma? The answer no, because this medication, the answer will be no, absolutely not, contraindicated. We don't recommend to prescribe propranolol for the patients from asthma or COPD. Okay, it's contraindicated to prescribe this medication to patients from asthma or COPD. They found also propranolol effect in general on when you give propranolol. They found propranolol decrease intraocular pressure, and this will benefit the patients from glaucoma. However, we don't use propranolol to treat glaucoma, because propranolol medication prescribed orally and as you are going to see systemic effect on the blood pressure, on the heart, on the lung, on the eye. So we prefer to go with the eye drops, such as timolol. And another beta blocker, we prefer to go with the timolol with a much better effect, and you can see it in the lowering intraocular pressure without affecting blood pressure, without affect the lung and or bronchial tree. What about the effect of propranolol in patients with diabetes? The most important one here, the last one, what they found there, we need to remember the patient with suffer from diabetes. Normally they are, if they suffer from hypoglycemia, when the patients suffer from hypoglycemia, what happened there? So again, we need to go back to the whiteboard. Okay, when the patients suffer from hypoglycemia, okay, and diabetic patient, when the patients suffer from hypoglycemia, so what happened there? This will lead to activate sympathetic system. So activation of sympathetic system will lead to the increased heart rate, palpitation, sweating, okay, a tremor. So all these related to the activation of sympathetic system. That makes sense for us. So diabetic patient, if the patient suffers from hypoglycemia, decreased blood glucose level, we have alarm system. This will activate sympathetic system to alert the patient you have hypoglycemia. Heart rate will increase, sweating, tremor. All these related to the activation of sympathetic system. What happened if you prescribe to the propranolol to the patient? Okay, so let me say you are going to see patients suffer from diabetes, and the patient come to the clinic suffer from hypertension, and you start thinking of prescribing propranolol to treat hypertension. Here they said if you prescribe propranolol to this patient, the result will be blocking sympathetic system. Propranolol considered like beta blocker. Propranolol block sympathetic system. In this case here, we are not going to see decreased heart rate. We are not going to see sweating or tremor as a predictive factor for the hypoglycemia. We can call this one like propranolol masks the symptoms of hypoglycemia, and the patient may die from hypoglycemia without alert. Okay, and again, this medication, they found also this medication decrease glucagon and decrease glucogenolysis. So to approach here, and the result will be by decreasing, this will lead to the hypoglycemia also. So we have two effects here. Number one, mask symptom of hypoglycemia and may cause hypoglycemia by two main effects here. Okay, this table very important table for the pharmacokinetic of beta blocker. As you can see here, we have list of medication. One of these medication work on the one of these medication work on beta 1 receptor, and we have less of medication work on beta 1 receptor such as acebutolol, atenolol, esmolol, metoprolol, nebivolol. Another group of beta blockers considered like non-selective, block beta 1, beta 2. We have carvedilol, we have labetalol, we have nadolol, we have bendilol, propranolol, and timolol. So this is a first question here. Give me medication block beta 1 receptor. So we have list of medication. Give me medication block beta 1, beta 2 receptor. Moving to the beta blocker lipid solubility, one important issue we need to highlight here, that you can see here for the propranolol, considered like highly lipid soluble medication. Propranolol will be easily arrive to the or across the blood-brain barrier and arrive to the central nervous system. For this reason, we use the propranolol for tremor and migraine. So this one could be used for migraine and could be used for tremor. Okay, migraine and tremor here. So for central nervous system, number one. Moving to another one here, we have nadolol. As you can see here, if you look on the half-life for the most medication, it's like 3 to 4 hours, 9 to 6, 7, 10, 11, 30. Then they said here it's like 20, 24. So the question, which of these beta blocker considered like longest half-life or has longer half-life compared with other medication, nadolol? Nadolol considered like longer half-life. Okay, this maybe presents some information for us regarding to the characteristic of beta blocker. Okay, speaking about first generation beta blocker. So we talk about first generation beta blocker considered like non-selective beta blocker, first generation non-selective beta blocker. Nadolol, we discussed it already. And the nadolol has long duration of action, like between 20 to 24 minutes. 20 to 24 hours, not minutes, sorry about that. Then we have propranolol, the first medication prototype, the original medication produced from beta blocker, propranolol. And this is, please remember, this group of medication, block beta 1 and block beta 2. So two medication will be blocked, two receptor will be blocked by this medication. Timolol, mainly available for the glaucoma and available in the market as ophthalmic or eye drops, and could be available oral. Moving to the sotalol, as you can see here, sotalol, this medication used for cardiac arrhythmic drugs, and this belongs to the category 3 according to the classification of cardiac arrhythmic drugs, and sotalol inhibit beta blocker at the same time, block beta blocker at the same time, sotalol work on the potassium channel. Okay, acebutolol, also they found acebutolol considered like beta blocker with a partial agonist with some activation of the receptor. Timolol, ophthalmic and oral, available as eye drops and oral, used for glaucoma, and they found timolol decrease intraocular pressure. I would like to go back to the table here to show you some important concept for the carvedilol and labetalol. Carvedilol, in addition to blocking beta receptor, this two medication also block alpha. So we can talk about beta 1 beta 2, and alpha will be blocked by these two medication. So carvedilol and labetalol block beta 1, beta 2, and alpha. Nebivolol cause vasodilation. This is in contrast with the rest of beta blocker. Nebivolol cause vasodilation through the releasing of nitric oxide from the vascular endothelium. And if you remember that, we discussed that in the previous slide and in the whiteboard. We said that beta blocker cause vasoconstriction in general. So which of the following beta blocker cause vasodilation? The answer will be nebivolol because of releasing nitric oxide. Okay, so moving to the second. So we discussed the first generation. We have nadolol, propranolol, timolol, and sotalol. Second generation, we have beta 1 selective. Second generation, we have beta 1 selective. Group of medication, we have atenolol, we have bisoprolol, ismilol, metoprolol, acebutolol. This is beta 1 selective and second generation. And as I said, acebutolol considered like a partial agonist. Acebutolol could be stimulate, and they have it has some activity to block beta receptor acebutolol. Speak about beta 1 receptor here. Ismilol, very short duration of action, IV, and used for the control acute L patient. Ultra short acting, beta 1 selective. This medication used for patients from cardiac arrhythmia, such as supraventricular arrhythmias. If you have cases such as thyrotoxicosis associated with arrhythmia, we can use ismilol, and please remember that this is for the emergency or like IV and acute treatment there. Okay, the beta blocker third generation. With the third generation, we have two groups. Group number 1 non-selective, and group 2 will be selective. So third generation, we start with the non-selective. We have carvedilol, labetalol. Carvedilol non-selective beta blocker and block alpha 1 receptor also. Labetalol non-selective beta in addition to blocking alpha. Labetalol used for emergency treatment of hypertension. So when you talk about emergency, here we talk about IV, because when you have patient come to the emergency room, we need to approach the patient with a critical case with the IV treatment. We can see the result directly for the patient. And labetalol oral considered like drug of choice for pregnant women suffer from hypertension. So beta blocker safe and during pregnancy. We have labetalol, carvedilol. This medication could be used for patients from heart failure with a low dose according to the activity for the beta 1, beta 2, and alpha 1 blocker. Moving to the selective beta 1, third generation selective beta 1. We need to focus on the main medication nebivolol, the most highly selective beta blocker. Okay, nebivolol, most highly selective beta 1 blocker. And nebivolol increased release of nitric oxide, and this will lead to the vasodilation. Some study found that nebivolol increased sensitivity towards insulin and may cause a risk of hypoglycemia, and there is no effect on the lipid and the patient with a hyperlipidemia. Okay, moving to the clinical use of beta blocker. This is general. It's not related to one medication or specific medication. In general, most of beta blocker might be used for the hypertension. Most of beta blocker might be used for hypertension. We can use the beta blocker for angina, for patients suffer from myocardial infarction, cardiac arrhythmia. We use beta blocker to treat heart failure. We use beta blocker for glaucoma. You use beta blocker for patients from hyperthyroidism to block symptoms. We use beta blocker for patients from migraine, tremors, anxiety, PTSD. So this is a list of clinical case indicated to use beta blocker: hypertension, angina, myocardial infarction, cardiac arrhythmia, heart failure, glaucoma, hyperthyroidism, migraine, tremor, anxiety, PTSD. Okay, is there any side effect? Yes, beta blocker may cause bronchoconstriction. We discussed that. Beta blocker may cause cardiac arrhythmias. Beta blocker may cause vasoconstriction. Beta blocker may cause sexual impairment. Beta blocker mask symptoms of hypoglycemia. We explained this one, mask symptom of hypoglycemia. We explained the peripheral vasoconstriction together. For the bronchoconstriction, we explained it again in the previous slide. We explained the mechanism, what happened there. So bronchoconstriction, propranolol must never be used. Propranolol contraindicated in patients with COPD and asthma. It's not allowed to use propranolol in patients with that because propranolol block beta 2 and this will lead to the acute asthma attack. For the arrhythmias, they said if the patient on a chronic treatment or the beta blocker never stop this medication quickly or suddenly, you need to decrease this medication, decrease them taking this medication gradually in order to allow the receptor to reactivate it again. Okay, adverse effect, we discussed the peripheral vasoconstriction here. We already discussed it with you. When you prescribe beta blocker to your patient, the result will be decreased cardiac output related to the blocker of this one related to the block beta 1, but they found if you block beta 2, this will lead to this will be available in the blood vessels. Okay, blocking beta 2, this will lead to the vasoconstriction and the patient start complaining from cold extremities, and this is worsens the symptoms of Raynaud's disease phenomenon. If the patient suffers from this phenomenon, this will worsen the situation. So if the patient suffers from peripheral disease, we don't recommend to use beta blocker non-selective propranolol. It's considered like contraindicated. Sexual impairment, we don't know exactly the reason or the mechanism why beta blocker cause sexual impairment. We need to take this in consideration when you treat your patient. You have to maybe bring the attention of your patient about this side effect and have a discussion with the patient education about the ability of this medication to cause sexual impairment. Important issue here, we already discussed it. They said beta blocker mask the symptoms of hypoglycemia, and the patient may die from hypoglycemia, from coma, but the patient may suffer from coma and death due to the masking symptom of hypoglycemia. Okay, this will conclude our lecture about adrenergic antagonist for today. So we discussed the alpha-adrenergic antagonists such as Prazosin, terazosin, tamsulosin, and Silodosin, and we discussed the clinical use of this medication. Then we moved to the beta blocker, and we discussed the selectivity, beta 1 selective, beta non-selective, and we have some medication belong to the beta blocker that block alpha, beta 1, beta 2, and alpha, such as carvedilol and labetalol. Then we move to the other medications such as reserpine and yohimbine as a medication affect the neurotransmitter uptake and release. We have category for alpha 1, alpha receptor antagonist and beta antagonist. We need to differentiate between the generation of beta blocker. We have first generation, second generation, third generation, and then we need to differentiate which one is like beta 1 selective, which one is beta non-selective, beta blocker non-selective, such as propranolol, timolol, nadolol, which one like coming with an increased release of nitric oxide and cause vasodilation. Then the last two slides we discussed the clinical use of beta blocker in general. We spoke about the angina, myocardial infarction, heart failure, migraine, tremors, PTSD. We have a lot of indication there. Then we conclude our topic about adverse drug reaction such as bronchoconstriction, peripheral vasoconstriction, masking symptom of hypoglycemia. So we need to maybe to know the holistic, complete picture of adrenergic agonist, alpha blocker, beta blocker, alpha 1, alpha 2. So all these receptor, we need to remember the effect of this receptor and what is the effect of medication on these receptors. Okay, at the end of this lecture, I would like to thank everyone for your listening and attending this lecture. Thanks so much and have a great day.